very much welcome. Last week we had from Dr. Shraddha, who presented a beautiful talk on what should be the applied surgical anatomy and how is it relevant for liver resection. So I decided that we should, as a surgical oncology student, you must really know what should be the way to approach if you have a colorectal cancer which is stage 4 with liver metastasis. So how to approach this as a surgeon? What is the general concept? Remember, initially when you all started surgical onco career, you're carried away by the UICC, AJCC staging, stage 1, 2, 3, 4. And you think that stage 4 is not curable. You all know that there are some cancer, there are only stage 1 and 2, that is well differentiated papillary CA thyroid in young people. There are some cancer where you have 5 stage. That is, you all know that it is available in Wilms tumor, nephroblastomas. There are some stage where stage 2 outcome is better than stage 1, and that is hepatoblastoma. Please read why it is so. And there are some stages where tumor marker are used, S1, S2, S3, and there are only 3 stages, that is a testicular malignancy. So in general, we think that stage 4 means advanced, last stage, not curable. Now with recent personalized medicine, proper approach to the patients in the era of immunotherapy, multimodality sequential treatment, lot of stage 4 patients are cured. Stage 4 testicular malignancy, stage 3 is cured with lung, liver, distant mats. If you have a CA thyroid in elderly people with systemic mats, they are cured. Renal cell carcinoma with lung or liver mats, sequential treatment by immunotyrosine kinase, metastectomy at primary and distal can also cure them. Peripheral soft tissue sarcomas or osteosarcoma bone tumor, when you are treated successfully, if they have lung mets, up to 16 lung metastasis, as long as you do systemic therapy and resect the metastectomy, they are cured. Luminal A or hormone positive stage 4 breast cancer, even if they have liver or lung mets or bone, with sequential treatment of both primary, secondary, and hormone therapy, and then CDK4 inhibitors and SBRT, they are also cured. So now there are a lot of cancers which are stage 4 which can be cured. Another example is colorectal cancer with peritoneal mass, stage 4, but with CRS hypex selected patient with the PCI are cured. Gastric cancer, low PCI like 6 to 9, less than that, sequential treatment, CRS and hypec, stage 4, they are also amenable for cure. So a lot of cancers now in stage 4 are amenable for long-term survival, which falls into the ambit of a chronic disease category, and we report them as cure in oncology. So colorectal cancer with liver metastasis or lung metastasis, or both in one patient, if treated rightly with systemic therapy, with or without bevacizumab, anti-EGFR therapy, targeted therapy, and sequential resection at the end of it, both at primary and multimodality are cured. I don't know how many of you are actually there, in all these IASO groups and ATCON, where I put everyday morning that day particulars, publications and papers which are of recent advances every day. Till now it was thought that when somebody has a colorectal cancer with liver metastasis lung, after neoadjuvant systemic, liver first approach was important. Means primary is never inoperable. You can always go and resect the primary by robotic colectomy or LAR, EPR very easily. Usually the inoperability is the functional liver residue in the liver. Can we remove all the metastasis by metastectomy or one hepatectomy, left hepatectomy, right metastectomy, right hepatectomy with left metastectomy? And then if you can get rid of all the disease in the liver or lung, if that patient has robotic VATS with metastectomy, then only you can cure patient. Then last you come back for primary. Because when you give a chemo or targeted therapy, rarely it happens that liver and lung disease is shrinking and responding. Primary is growing. No, it doesn't happen. Always primary responds very well. So primary would have shrunk unless a patient has a intestinal obstruction, perforation or bleeding. We normally don't go to primary first. First liver first approach. Liver metastectomy, get rid of them. Lung if they have. Last come to primary. Because so far there are so many studies which showed in a colorectal with stage 4, if primary treatment is done without systemic metastectomy, there is no survival benefit. Complications were high. Imagine this patient needs to be fit to take 4 to 6 months of chemo or anti-EGFR therapy or bevacizumab or immunotherapy, and you concentrate on the primary, you do resection, you anastomose, 3 weeks you can't give a treatment. Or you can also end up giving a problem to the patient with like perforation leak, and then patient develops surgical complication, wound infection, never takes a systemic therapy or liver metastasis, then they're not cured. Unnecessary, you added a lot of morbidity to the patient. So in view of all this, so far it was proved and accepted liver, lung first, last primary. But 3 days back, those of you who are in minimal access surgery WhatsApp group or IASO groups or GI group, I put a new recent paper for the first time which showed that liver approach first and primary late had a different determinant. So you read about that, what paper I put it. If you are not there in there, be in all this IASO and all the groups, so you can read all the papers I put. So I bring warm regards from my institution where I work in Bangalore. So now if you see the concept, we all know that in metastatic colorectal cancer, when you give early chemo, we normally analyze within like 4 to 6 weeks, is there a ETS? It is called as ETS, early tumor shrinkage. People who have early response in liver and lung metastasis in colorectal for neoadjuvant treatment with anti-EGFR therapy like cetuximab or panitumumab, they are the long-term survivors. They have a complete response. So you look for this group of ETS, early tumor shrinkage. We may not operate at 4th week, 3 weeks. We just do a scan and look at 6 weeks. Are they ETS? Then you can operate by roughly 2 months of neoadjuvant treatment and their long-term survival. So when you manage a metastatic colorectal cancer, it's a MDT, a diagnostic radiologist, medical onco, radiation onco, surgical oncologist who deals both the liver and colorectal. Intervention radiologist is very important because in this you have TACE, so you have a chemo that is a transarterial chemo embolization, TARE, transarterial radioembolization, that is a SIR spears, atrium spears, or you have a glass beads which is Serra spears, or DC beads, irinotecan beads, then RFA, microwave ablation. So they are all part done by intervention radiologists before or after. That initially we used to do ALPS, that is the association liver partition and portal vein ligation for stage hepatectomy. You know that if you transect the liver, keep the pedicles, and then come back, within 3 weeks the other lobe compensatory hypertrophy. So if the liver response is very less, then you can actually go back, if the liver volume is less, by doing ALPS procedure it happens. But now morbidity is very high, bile leaks are high and complications, so it has not become very popular, but you need to know all this. And now very big way, liver lesions, HCCs and liver metastaectomy because of colorectal, those are not resectable. Radiotherapy, SBRT has come in a very big way now. High dose of radiation if you give can also take care. So all the people in the gambit are required. Why MDT management is important? A institution where colorectal cancer with liver lung metastasis are managed by MDT or standalone surgical onco, one medical oncologist. You can see that if any of these patients end with liver resection, then look at the survival, they have 60 to 70% 5-year survival many times. Those patients who keep on giving chemo, bevacizumab, anti-EGFR, primary you go and put lap or robot and remote, not able to manage the liver and lung metastaectomy, then their survival is 26 months. So look at this, 26 months in a group managed by MDT where metastaectomy at liver is done, managed by single team of onco, like one medical surgical sitting in one place and then not going through the MDT where the imaging specialist, intervention radiologist and surgical oncologist who is trying to do liver resections is not there, then their survival is 26 months. If you do it 65 months, which we thought it take it as almost cure 60%. So the resection of unresectable. Now when a patient of colorectal with liver comes, we classify them into group A, we classify them into group B, and then we classify them into group C. Group A means directly they are resectable, single lesion less than 5 centimeter or less than 3 number, and they are already available. It's very easy and we think that it's very easily resectable. So those patients are group A. Group B is at presentation liver is not resectable because of the size of the lesion, more than 5 centimeter, more than 5 lesions close to the portal vein IVC, or if you resect functional FLR, functional liver remnant is not 30%. That is type B where neoadjuvant treatment is done, then you make the mobile. Type C is whole liver bilaterally studded with multiple mats or lung, liver, brain, systemic mats. They are never going to be amenable for any surgical resection. Then they are type C, then the intention is palliation with sequential treatment. They live about 3 years, 5% can live 5 years. So when you look back all the studies currently that are published and look at this, clearly a criteria for non-resectability and resectability has been mentioned, and this is the publication I have quoted. Okay. Now, if you look back the various trials which are important in our colorectal cancers with liver metastasis: Crystal trial, Opus trial, Kelim trial, and Poacher trial. Now there are even more trials where if there is a general oncology, means person who is not amenable, or you take it only a GI surgeon is there, or a person who is not a part of MDT, or a single surgical oncologist with one medical onco, 16% was the chances of survival or ending up with liver resection in the Opus trial. So where Kelim and Poacher went into MDT surgical oncology tumor board, when they are discussing tumor board where you have all the people, the surgical oncologist who is trained both to do primary and liver, and then the intervention radiology, medical oncology, and then rehabilitation, everybody, 79 to 70% of these patients ended with liver resection, and the survival jumped to 60%. So these are 4 trial done in an era outside oncology department, cancer center in general oncology or GI alone, trial done in a MDT in a oncology cancer center with liver resection possible, Kelim and Poacher. Look at the survival. This shows that multimodality is important. Now there is another group called as Liver Met Survey. You can read it. I am a part of this particular study where globally we are multiple institutions, 180 centers who do liver resection, primary with the robot or lab, and then we do a MDT approach across the globe. Or a part of it is called as livermetsurvey.org. Where a part of it, it is maintained in Paris by Rennie Adam from Paul Bros Hospital, and about roughly 11 to now today, almost as of today, 20,000 patients are recruited across 180 centers in 56 countries. In that group, when we looked at it, for more than 20,000 patients, stage 4 patients who actually ended up with liver resection, survival was 40%. Look at the last curve, 10 years. Those who didn't operate, 10 years was 0%, less than 8% lived by chance in 5%. So this shows that metastectomy after sequential neoadjuvant chemo with or without bevacizumab or anti-EGFR ends up with cure in many patients. So now when you have a colorectal cancer, either they come with primary with liver lesion at presentation, or if you have treated successfully a colorectal cancer with surgery like CME, Japanese D3, and complete mesocholic excision or TME, and then you have given them chemotherapy, then when you follow, they develop liver metastasis, which is synchronous. So metachronous, synchronous. So when you have a colorectal cancer with liver metastasis, at presentation roughly 20 are resectable, 80 are not resectable. Please remember this. These are the data I have picked up from the Liver Met Survey and also from the multiple publication of ASCO. So today as a student, if somebody asks, roughly colorectal cancer with liver lesion, 20% of them you can actually not resectable, and remaining of them have actually resectability. So those patients who are not resectable, if you give neoadjuvant chemo, 20% of them become resectable, and total resection then becomes 20 plus roughly 50-20, so 30% are resectable. This is an old school of thoughts. Now I will come to new. So this is about the Liver Met Survey I told, where roughly about 30,000 patients are operated and liver resected, and my center actually is a part and I am there part of it. So this is the Liver Met Survey across the world. All the centers across the globe are amenable for that. So we will see about this. Okay. So these are the statistics I will cover. What is this show? This show that at presentation, about 5% of the patient across the world, remember, they are not high-end centers. Every center may not be your center, my center, where we have robot, we can do liver resection, we have MDT, and we use immunotherapy, targeted therapy, and there are intervention radiology, microwave ablation is there, portal vein embolization with compensatory external reproductomies are done, they are not there. Worldwide, if you look back, only 5.44% of the patient undergo surgery. Unfortunately, 94% of the patients don't undergo any resection, which is very sad. So initially, the definition, Rees et al. Definition which persisted up to 2001 is, if you have a colorectal with liver mets, if they are metachronous lesion, means you're treated primary colorectal, then they develop. They are always a better. Remember, a patient who starts as stage 3, 1, 2, 3, and then becomes stage 4 are better biology. Yeah, rather than a patient at presentation, they present as stage 4. They are aggressive tumor, aggressive biology. So synchronous, metachronous. Initially, metachronous liver lesions with colorectal were resected. Unilobar, single lobe, less than 3 metastases in size. None of them more than 5 centimeter size. Resection margin recommended was 1 centimeter. In liver, if a disease in the caudate lobe, there is IVC there, where is 1 centimeter available? Or if you are just, segment 5 and 8 or 4A, 4B, you are very close to middle hepatic MHV, and you may not have a margin, and then if you transfer MHV, you have to take a trisegmentectomy or external reproductomy, then there is no liver volume. So 1 centimeter is now not required. Any micro, like in CA breast, negative margin or 1 to 2 millimeters accepted. And CEA less than 100. These were the Rees criteria. When these criteria were put, only 15-20% were resectable. Now people don't accept this criteria. Now we have an extended criteria where the only criteria is, if you can do liver metastectomy with R0 or R1. R1 is when you are very close to IVC microscopic thin layer sometimes. As long as 30% of liver remnant is intact, 30% of liver remnant is intact, rest you can remove. Now none of them is inoperable or non-resectable. That is Rene Adams criteria published since 2009. Even if they have an extrahepatic disease like portal node, solitary solitary bone mats or lung mats where you can resect them, or isolated peritoneal disease which are amenable for resection and HIPEC, even then they are amenable for long-term survival as long as you can do multimodality treatment, neoadjuvant systemic therapy. Sequentially, all the metastatic disease can be removed. Is it true or not? Now we will look at the liver met survey. You can see that here patients with 3 metastasis, 7 metastasis, more than 7. Can you look at this? Even though patient with 3 metastasis and less than 7 had a higher survival, even those patients who had more than 7 metastatic disease, as long as you can do hepatic resection in sequentially after chemo, they still derived long-term 10-year survival benefit, which means number of lesion is not a contraindication. Look at this again. Even though less than 3 lesion had a 45% 10-year survival, more than 7 lesion had 28% survival, even lesion as high as 8 nodes and above, 8 nodules and above, they also had 21% long-term survival. So this means, as per the data which we have published, I am also a part of it, number of lesion is not a contraindication as long as you can resect. Now we will come to, do we have to do 1 centimeter resection? This is a study from Haas. Even though R0, CC0 is the best in oncology, where 45% have 10-year survival, even accidentally you have a microscopic R1 margin positivity, don't worry, still they have 37% 10-year survival. So now you can see that you have a good leverage. You are around IVC, you are around caudate lobe, you are around diaphragm, or you are around a vital organ where you have no margin because you have to resect the vascularity that has an impact on the quality of life morbidity. Still 37% is there. So R1 is not a contraindication in selected patient. Now people say, oh, colorectal with liver, nothing should be there outside. Extra hepatic concomitant disease if you have, look at from the liver met survey. As long as you can do sequential metastectomy, even though liver alone disease without extrahepatic had a 42% survival, 21% of the patients still derived benefit if they are actually extrahepatic disease. So this is something which is very important to understand. Where are usually the extrahepatic disease that comes? Portal node, isolated bone mats, or a lung metastasis. So in liver met survey you can see extrahepatic disease, even that can be resected, or isolated supraclavicular node. 21% had a 10-year survival. So that is not a contraindication. Now we will come by size. Traditional thing was 5 centimeter and above. The biology is bad, they are not amenable, they may come back. Now we look at the liver met survey where we publish large amount in lakhs of patients. You can see there are 50% of the patient where size was 3, blue 5 centimeter of the lesion, almost 26%. And then if you look back the green, then they are about roughly 18%, and the size of those lesions were up to 10 centimeter resected. Then there are those 3-4% where more than 10 centimeter also we resected. Can you look at it? So this is the importance for us to know. 1 minute, just be online. Charlotte, HIA therapy is busy. Send me by WhatsApp. Okay. Apologies. I wanted to get one video for you about the next HIA therapy. I'll put it right now. So you can see that more than 10 centimeter are also operated. Now we look the survival. Can you look at this curve? So green, I know, less than 3. Then a light pink, about 5. Now concentrate on the lower 2 curve. Blue one, dark red. More than 10 centimeter lesion still resected. How many patients are there? 16,529 patients in our group. 16,529 patients. What is the survival? Still 27 to 28, 10-year survival. And then if you look back the dark red, where more than blue, pink, more than 10 centimeter, even they derived benefit, which means size of the lesion is not a contraindication as long as you can resect down the line. Now, second thing is less than 5 metastasis in the liver should be there. Wrong. This shows more than 5 metastectomy. Can you look back that, green? They are more than 5 metastasis. Even they derived a survival benefit. So this is something I wanted. Now, unilobar, bilobar. You can see this green line. Bilobar disease. 36% in our group had a bilobar disease. Yet, neoadjuvant chemo with or without cetuximab based on KRAS status and bevacizumab and then resection in liver, they still derived close to 20 to 30% 10-year survival. So, even that is not a contraindication. Now, another thing we will look at is, can a second surgery be done? Today, you have a colorectal with liver mets, you have done neoadjuvant chemo with or without bevacizumab and cetuximab. Then you have done a liver metastectomy, say right hepatectomy, all the lesions are removed. Then you have done a primary. Then down the line, 2 year, 3 year, he develops another lesion in the remnant of the liver or other. So this is a second hepatectomy. Patients who underwent second hepatectomy also derived benefit. Whether you operate in synchronous or metachronous, both have survival benefit. Look the lower curve. So if you look at the green, it is metachronous, means down the line they develop liver lesions. Red is at presentation primary with liver. In both of them, when you operate it, survival benefit is there. So this is one of the patient. Can patient undergo 3 hepatic resection? You have done a liver metastectomy, treated them with chemo, then down the line somewhere around 1-2 year, another lesion comes, you have done now left hepatectomy with central lesion left. Can you do third metastectomy? Such patient we had 441 who did 3 liver surgeries in colorectal. Still 37% 10-year survival, which means don't lose the hope. Okay. So now this is what I told. There are 3 groups when a patient of colorectal with liver comes. You have to classify it as type A, type B, type C. Type A. See that single lesion, peripherally situated, less than 5 centimeter. You can easily resect. Upfront, you can go and resect. They are called type A. You operate, then do adjuvant chemo. Second, can you see this multiple lesion in both lobes or more than 5 centimeter, especially the second one? Can you see only caudate lobe, coinot segment 1, 2 and B is left, rest nothing is left. So then it is almost very, very difficult for you to take it up. Here you need a help of neoadjuvant treatment, and then those are the patient who will become operable. This is type B. One day they end up. This is type C. Can you see this? Studded cannonball lung, bone mats, multiple bilobar mats. Unlikely that these patients would ever actually, end up with treatment. And this is the patients who may or may not have any benefit. And these are type C. Here there is no surgical role. Then you actually end up with palliative treatment and chemo. Okay, this is type C. So your funda should be very clear. So middle one, optimal neoadjuvant treatment, chemo, anti-EGFR therapy or bevacizumab, depending on what you want it, you are starting, and then you down the line, you go ahead and do the surgery. Okay. Type C, no surgery, so sequential chemo with or without anti-EGFR. So our aim of objectivity and strategy in metastatic colorectal cancer is to increase the number of patient suitability where you can actually go ahead and do a liver resection. Okay, how do we do this? Now, never ever think that a patient of liver lesion is a palliative in MDT until you complete 2 months of neoadjuvant chemo or targeted therapy. Look at this patient. Very little part of the liver is left behind. You thought this patient will never end up. The same patient after neoadjuvant treatment. Can you see now? It has shrunk so much, you can just do 2 resections and rest all are amenable for liver resection. So this is a curative patient. Second thing important is, another mistake what medical oncologists do is they keep on giving chemo. They'll think, okay, there is a liver metastasis, so let's actually keep giving irinotecan and then keep giving oxaliplatin. If you give any chemo more than 2 to 3 months, even after that, if the patient is resectable, they develop what is called as blue liver because of vascular problem, or they develop yellow liver because of steatohepatitis, and blue liver because of vascular congestion, where irinotecan and oxaliplatin induces. Then those patients become palliative. They will die of liver failure if you do the metastectomy, where you can go and operate, but there is no functional remnant available because of a liver toxicity. That is why right time to get the evaluation is after 4 cycle. Don't go beyond 5, 6, 7. Then you think that I'll give more, it will shrink more than small. Then patient develop blue liver, yellow liver. You cannot do hepatectomy. And we know that if you don't do liver resection, what happens? None of these patients are amenable for curative resection, right? So liver resection is the most important thing in this. So if you don't do that, then these patients will never ever end up with curative resection. That is one of the reason you must know very, very clearly that don't give chemo unnecessarily too long and too much and then end up with a problem. This is very important to understand. So tell your medical oncologist, please, for God's sake, don't give chemo or for beyond 4 cycle until I evaluate. Otherwise, they will never ever understand what to do that. Okay. So this is something which I want you to know. Next thing, you can see that sometime if you give more than 2 to 3 months chemo, the imaging becomes normal. So what does this imaging normal suggest? So we think that, complete response happened. Now there are 2 problems. How do you know where to go and resect? Second, do they really need resection? So complete response seen on PET scan or MRI or CT. Remember, for liver metastasis evaluation, MRI liver is more superior than any other modality. So we always do an MRI liver before we plan any definitive treatment. It will show more lesions. And intraoperative ultrasound is extremely important. So if you think complete, is it a myth? I will show you now a presentation and publication. Now we found in liver met survey, if you give more chemo, we analyze patients who underwent less than 6 cycles, patient who underwent more than 6 cycles. So you can see that if you undergo less than 6 cycle and also also more than 6 cycle, or patients also undergo after one line chemo and after multiple line chemo. So we analyze this particular group. Patients who take more than 6 cycles, survival drops down. See this from 40-50% to almost 20%. So please don't operate after more than 6. Ideal is 4 cycle. If you tell first line FOLFOX, FOLFIRINOX, the more number of line of chemo you use, survival drop down. Can you see this? First line, you are at almost 30%. Second line, 5-year survival drops down to 30. Third line, none of them are usually available 5. So the message is don't keep giving chemo. Please actually look at what you do. Second, longer chemo. More, less than 4 to 5 cycle, morbidity after liver resection 20%. If you keep giving 6 to 9, morbidity after liver resection 40%. If you give 10 cycle undo 60%, they will all die with liver failure or infection complications. So the message is less chemo when it is operable, operate. Some lesions should be seen so that you know where to go and remove. Less number of lines and operate. So this is very, very important that the longer you do. Now, if you are given chemo and everything has disappeared, so does it mean? This is a beautiful paper I picked up from JCO 2006. 66 patients they analyzed where all the liver lesion disappeared on a PET scan MRI. Macroscope, then they underwent liver lesions excision. So you can see that 20 of the 66 still had a disease. When PET was negative, MR negative, 20 of the time disease. Out of 66, 20 still had a residual disease, microscopic. So in this group, now there are another patient who didn't undergo surgery. 15 patients who underwent resected, there was viable tumor. And those patients who, in spite of complete response, didn't undergo surgery, how many? 23. They developed recurrence out of 31. Which means 83% of the patients are not cured even though they are clinical complete response. If you go back and resect, 12 out of 66, roughly about you can say 20% had a residual disease. Remaining 23% developed recurrence in the same place. So the message is complete response radiologically is a myth. You have to go back and resect them or at least do a microwave ablation to kill the viable disease. Otherwise 23% already there is a disease or remaining 23 will recur. So in liver met survey when we looked at it, what looked to be a complete response when we operated, which was 7,740 patients. Can you look back in them? So 8% progress if they don't operate it, and 65% still had a disease. Only 5% were true pathological complete response. Clinical response, radiological, translative pathologic is 5%. 95% need surgery or some form of liver directed therapy. So this is very, very important for you to know. This is what I wanted you to understand. So you can see that those patients who had complete response, operated, not operated. Those who are resected, 40% at 10-year survival, those who didn't undergo resection, less than 10% 5-year survival and 10%. So that is why you have to tell your medical oncologist, please don't wait for radiological disappearance of the disease. Then you send to me, I don't know when to operate because most of them will recur, there is a viable tumor. Please call us when the tumor become operable so we know where it is and we can clip it or we can operate it. And that is something which we wanted to understand and to know this. Okay. Now these are the other things where we looked at the complication. Even on second hepatectomy and third hepatectomy, complications are highly acceptable and you don't have to worry about this particular patient. Still they are amenable. Okay, so these are the data which I showed. Now, we did a study in India which were non-operable resectable patients. We give neoadjuvant cetuximab chemo and then we did a extended surgery. Now remember, by 4 to 6 cycle of the chemo, if the patient is not resectable, functional liver residue is not more than 30%. Then by giving more chemo, that patient is not going to become operable. More chemo, yellow liver, blue liver, complication more, mortality more, survival down. So what should you do? You have to change the strategy. What I do then? Now what I learned in Taiwan in Veterans Hospital, I tell my intervention radiologist to go ahead and do a portal vein embolization. Once you do portal vein embolization, say right lesion, all the blood for next 3 weeks will go to left lobe of the liver. It will do compensatory hypertrophy. Then you can do a extended trisegmentectomy, that is a right hepatectomy. Only caudate lobe station 2, 3 are there. In roughly 3 to 4 weeks, compensatory hypertrophy happens. So this is a case you can see that I did a portal vein embolization, gave 1-2 chemo during that time, then the liver compensated on the left side, only caudate lobe station 2, 3 are left. Can you see this? Only left hepatic vein. So this patient survived and they have 10 years survival. So this is very important for you to understand that number of metastasis doesn't matter, size of the metastasis doesn't matter, extrahepatic disease doesn't matter. A very important area of vascular, if you have to do R1, it's okay. First hepatectomy, second hepatectomy, third hepatectomy you do doesn't matter. As long as synchronous or metachronous doesn't matter, which means now with this new evidence based, I told you, expanded indications, you can actually now do resection for very high amount of patients. So this is something. Now any patient you plan to do a liver resection, you know that there is a software in the CT scan. Do a very good triphasic CECT of the liver. Beautiful. The software in the volumetry will analyze what is the weight of this liver. This has given this liver has 1.5 kg 07 gram. This is the volume. And now I will tell my person, okay, this is the tumor I'm going to remove. I mark it. They remove that. They will say, okay, 242 grams of the liver you are going to remove. Then they will analyze what is the remnant of the liver and what is the FLR. So normally, if it is a normal liver, non-alcoholic, healthy, young male, not given chemo, ideally 25% is enough. If you are given extensive chemo 30, if it is a cirrhotic liver, you need 40. So this is a future liver remnant, FLR, you need to look at it. So this is what, roughly 30%. But if you give more chemo, then this has no value, and then this will actually, the FLR result will actually change completely. So this is something which I want all of you to really know this, okay? So now if it is unresectable, that is when you do many other options. What are the other options we do? You can do a portal vein embolization, wait for compensatory hypertrophy to extend it. Or during surgery, you can do cryoembolization, or you can do microwave. Microwave is superior to RFA for the other lesions. So you can leave the left lobe and those 2 lesions you can ablate. Or what is done in Paul Bros Hospital where I got trained and I learned, stage hepatectomy. So you have, see here, there is hardly anything. Stage 1, you give neoadjuvant chemo 4 cycle, then go on to the right hepatectomy. See this? Then you continue with remaining chemo, allow the liver to grow slowly, then you do second hepatectomy, then only central lesion, liver lesion is left. So 2-stage hepatectomy. Neoadjuvant chemo, 1 hepatic resection, continue chemo, then other side hepatectomy. So the liver remnant in the middle part, you can see that what it is there, that grows up. This is something which I want you to know. So this is what is FLR. Normal parenchyma 30%. If it is not there, portal embolization, then compensatory hypertrophy, and then you do this. This is something. Or you can see that you can do non-anatomical resection. Same time when you do a non-anatomical resection, you can ligate the portal vein, put the glue, then go back for chemo, come back for the patient, and then you do. You can do all that robotic, you can do laparoscopic, you can do open. Or you can request your intervention radiologist. Your intervention radiologist, you can request them that can you please see this, how they have gone through the vein. They put a coil and they have occluded. Then only all the blood goes to the left lobe. Then you can come back and then you can do a trisegmentectomy. And then you can actually do this particular surgery. So this is something you can do. You must understand to know that. So now, if we do all this ancillary procedure, what are these ancillary procedure? Microwave, with hepatectomy, 2-stage hepatectomy. Then you have done cryo, or you have done a portal vein embolization, then you have done, because there was a concern if you do portal vein embolization, liver met survey, using these ancillary procedure, making them operable when they are inoperable, then doing hepatectomy. You can see that we had 1,820 such patients in our survey. Can you see them? Even in this group with portal vein embolization ancillary, the survival was still 35% in 10 years, which means it is not determinant. Whatever it takes to enhance the liver volume, like ALPS procedure, if you can do portal embolization and then do stage hepatectomy, still you go ahead and do, those patients are survived. I would want all of you to read about ALPS. Last time I think Shraddha briefly touched it. I used to do it before, robotic, now not very popular, where you do a portal vein, portal vein embolization, then you induce and you split the liver. Can you see this here? Read about this, Annals of Surgery, this volume. You split the liver, leave the liver in situ, close the abdomen, come back in very short time, in 2 weeks, 14 days, liver compensate, go back, now you can resect the tumor and remove off that tumor. You just split the liver, keep the pedicle intact, go back in 2 weeks. As early as 14 days, it becomes compensatory hypertrophy. So this is ALPS procedure, but morbidity was very high, so people are not very in this era where you have a panitumumab, cetuximab, bevacizumab, or now most of these patients, what I do is I just put a robot, then I go and dissect the gastroduodenal artery, I ligate the right hepatic artery, I do a cholecystectomy, then I ligate all the branches of the gastroduodenal artery. Through the gastroduodenal artery, I put a chemo port into the hepatic artery. It is called HIA therapy. Then I do hepatic infusion artery through a pump. And beauty of this is when you give a chemo, the first pass metabolism is liver, right? When you give systemic chemo, all the chemo is destroyed in liver. By the time it reaches liver, it has caused side effect, hair loss, bone marrow suppression, and skin change. But imagine if the disease is in the liver. We know that in the liver, normal lobe of the liver is predominantly supplied by portal system, and then the hepatic artery predominantly separates the cancer. So we know liver has dual blood supply. 70% of the volume of blood comes from portal, less than 30 comes from hepatic. But 90% of oxygenated blood comes from hepatic artery, only about 10 to 20% oxygenated comes from portal vein. Normal liver predominantly is supplied by portal. The liver cancer metastasis are supplied by hepatic. So if you cannulate the hepatic artery, you give a high dose chemo into the hepatic artery directly, it goes to the liver cancer, then the normal liver will first pass clear that, then goes to hepatic, go to systemic, no systemic disease. So imagine what a beauty, no side effect in the systemic, first pass liver metabolism, everything dies. High dose you can give directly into the artery. Remember, all the chemo medical oncologists give is a vein chemo. Hepatic arterial chemo is done in advanced head and neck cancer, where you cannulate the artery and give, or you do for the retinoblastoma, you cannulate the ophthalmic artery and give very low small dose, or into the hepatic artery. So we do in my center a lot of this robotic port placement into the hepatic artery. If you visit my YouTube, Dr. Somashekhar SP, I have put a video of how to put a robotic port into the hepatic artery during colorectal max. And then so what I normally do is I do neoadjuvant chemo with targeted therapy. If they are not resectable by portal vein or whatever, multiple bilobar mats, they are all palliative. I put robot, I then put a port into this, and then same day, next day morning, patient takes chemo. 4 cycle, 2 months, then they become resectable. I go back with robot, primary surgery and liver metastectomy we do. So you can watch this video. I'll see at the end of my talk, if I have a time, I have requested my Kushal, my fellow, to send my video which we did recently. If I comes, I can show you a little bit about that video. Otherwise on my YouTube that is there. So ALPS is also another procedure. Intrahepatic artery, this one is also another procedure. So see, this is about the ALPS. You can take this particular paper photo, read about it. It's nice to know what is this procedure. In exam they may ask how to induce a rapid left lateral. In 2 weeks you can operate actually. 10 to 12 days it happens. See how the other lobe increases. You split the liver and keep, that's an ALPS procedure. So that's very, very useful. See this, and you can go back and operate this particular patient if you can do. So this is what I told you. even 21% survival if you can do all this procedure, intrahepatic artery, HIA therapy, all procedure, portal vein embolization, there is. That is why you need a multimodality. Why you need a multimodality? A medical oncologist should know any patient which looks to be inoperable with liver lung mets can be cured if you involve a surgeon. They should also know that don't give more than 4 to 6 chemo. Please send them when some lesions are there so you can localize and remove, because complete response on imaging is a myth. There will be a disease. Don't give more chemo unnecessary to cause yellow liver, blue liver. Don't give second, third line chemo, survival is decreased. So that's why medical onco needs us. Timing of surgery is ideal after 2 months, improved survival, resectability. Why we need medical onco? Only 10% are type A, resectable at presentation. Type B, predominantly remaining 80 are not resectable. We need medical onco to give chemo, cetuximab or panitumumab or bevacizumab to make them operable based on the HGS. So you do MSI, MMR, immunotherapy required. Then even after you operate, 1/3 will recur in the liver. So they may need second, third surgery. So adjuvant chemo is required. So to prevent, that's why we need each other. That is one of the reason you need a MDT. So now with all I spoke, what we thought as 10% resectable with targeted therapy and many other, now you can know that more than 50% now are resectable. There is nothing called non-operable in liver. You can either do hepatic artery port, ALPS, portal embolization, neoadjuvant treatment, targeted therapy, split stick, and you can 50% of the patient you can cure them. So timing is very important. Right time, early intervention important. Don't wait for a lot of chemo. Don't overtreat the patient, give complication. There is nothing called complete response, very few of them. So you need to go back and then think about this. That's why you need a multimodal approach. So both of us need. So this is a study which I published. You can go back and read in India, where those who are inoperable, 76 patients, this was an old study which I published, 49 were males and median age. And you can see that, at the presentation, elderly patient, even 70, 60 were there in my group. They presented with right colon, transverse colon, left colon, rectal disease. And these were the liver resections I did out of these 76 patients. Bilobar was multiple. You can see 58% bilobar, 68% multiple. Rectum was 37%. More than 5 centimeter lesion, 53% in my study. Right lobe, left lobe, multiple lobe liver lesions. The tumor were like this, primary with liver. Can you see this? 3-4 lesions. So these patients, multiple lesion, when I gave chemo, you can see how the response with the neoadjuvant cetuximab, very small lesions. These were some of the examples. Big lesions, now I can just cut here and keep the left. We use multiple modality like portal vein if they are not operable. And stage procedure, you can see this. Right hepatectomy with central hepatectomy with right colectomy. Extended left hepatectomy in this case, which I have shown. And left hepatectomy, right hepatectomy, only central lesion is left behind. Portal vein embolization, extended right hepatectomy in this case. I could see that 63% of the patient who are not operable resectable, I could resect in my patient. So complete response was only 10%. Remaining all had some disease when we operated. 63% of the patient who were thought to be not resectable, I resected it. And we found 20% of the patient had this early tumor response who were KRAS wild type. So the message was 79% early responders are long-term survival and they're resectable. We presented this in the ESMO. Then we published in Indian journal. Normally, the current rule is rectum, do 2-stage approach. Liver, then rectum. Colon, do both together. However, if you have a robotic, because the morbidity is very high, but if you do minimal access robotic or lab, like in our case, we do same time, liver and this together. So you can read this. I published this paper, assessment of tumor response and its outcome. And we also, it is published in Annals of Oncology in 2012, volume 23. You can go back and read. So where we found that the median survival of these patients was extremely good. Now, we also analyzed in our group that even if there is a peritoneal disease with concomitant liver, if we can do liver resection, neoadjuvant treatment, then peritonectomy and HIPEC, even these group of patients, I had 37 patients, liver, lung and peritoneum, they had a 32-month survival and 1.5% 30-day mortality and morbidity of 11%. So this is published in NMJ journal, which we published. You can go back and read that even if there is a low PCI, peritoneal involvement, you can actually go back and then really treat and then do. So what are the improvements, key points for success? To expertise, learn this. I traveled to Paul Bros Hospital way back in the year 2000, almost 25 years back. Learned from Rennie Adam, and then I learned also from Bismuth. Then I traveled to Taiwan in Paul in Veterans Hospital. I learned portal embolization, extended hepatectomy. So we learned expertise. I went back 25 years back, came back, learned split segment, liver resection, robotics, then extended hepatectomy. So you also travel, learn from India. Everybody knows, all your colleagues, your teachers do extremely good job in all the centers in India. Build up a team, do a MDT, tell the medical oncologist, look, we can resect both lung by robotic metastectomy, liver, various technique, I can make it amenable. So all of you, if you join hand in an MDT, you can actually go back and do a very good resection. So it is not a pessimism, but it is a positive attitude. So this concludes my talk. What I will do is I will see that if Kushal has sent me my video. Let me check. If I've got the video, then I will show that particular hepatic artery video. Otherwise, I will take the question and answer, and you can actually put the Q&A there, and I'll answer in the next 10 minutes. Let me just check that if Kushal has sent and I can use it. Okay, I think I'm not able to retrieve his present, last case we did. But you can all visit my YouTube channel. So what we normally do, it's okay. Don't send the video. Just send the PPT in WhatsApp to me. That will come. I'll just show to the student. Okay, so until he sends the PPT, let me look at all the questions which are available. Okay, I'll go to the chat box. Okay, first question. Post-primary HCC hepatectomy margin is 1 centimeter. No. Now you aim for 10 millimeter margin. But when, if you have a caudate lobe tumor or you have a tumor very close to MVT, now negative margin is adequate. Less than 2 millimeter margin, locoregional control is same as 1 centimeter in hepatectomies for even HCC, not just colorectal mets. Okay, this is the first answer. So there's another question. What do you label as non-surgical? I told you type C. Type C is what? Non-resectable extrahepatic liver disease. Non-resectable or bilobal multiple studded tumor. That too, bilobal multiple tumors, what I normally do is robotic. I put the hepatic artery and I give 4 cycle because no complication. High dose chemo through the hepatic artery goes to tumor, normal liver is spared. First pass metabolism, everything is washed off, no systemic. If you see the largest experience of HIA therapy, hepatic artery infusion therapy for colorectal mets through a port placed in hepatic artery is from MSKCC. Please read it. I got motivated from them. Many years back, I had very 2 super VIP patients, and in spite of neoadjuvant chemo, cetuximab, multiple liver mets. Then I sent them to my colleague in MSKCC. They put a port and they resected. Then I thought, why should we not start back? People used to do in open technique. When you do a laparotomy and do it, it takes like 4-5 hours. Patient is in pain. Patient stays in hospital 5-6 days. 21 days you can't give chemo. So I started putting in robot. Actually, the first robotic hepatic artery port in the world, I put it actually. And we now routinely put in robot. So then these are non-resectable. So there is if the FLR is not 30% in spite of all the things I told, they are non-resectable. Non-resectable extrahepatic is non-resectable, but they are now only 20-30%. More than 50-60% you can actually control. Next question Sania is asking, after portal vein embolization, hypertrophy occurs, is chemo continued in that period? Yeah, it's a very good question. There are two schools of thought. People think that when you have done portal vein embolization, you have given time for the patient to grow. Chemo means suppression of rapidly multiplying. So people are worried that if you do portal vein embolization, during that period you give chemo, then the amount of growth of volume proportional is less than not giving chemo. So it is not contraindicated, but most people complete the chemo, which is about 6 cycles, so patient is protected. Then during the 3 weeks period of portal embolization and growth, they try to not give chemo so that there is a rapid growth, quickly go in and operate so you can go back. So this is a lot of papers which are presented. Then synchronous rectal cancer with liver metastasis. How do you decide between induction, consolidation, CRT? Okay, now this is a very good question. There is a beautiful paper which has come and presented that this is if you have a rectum, because there is one more modality in rectum, that is RT. How do you integrate? If you have a rectal cancer which needs primary chemoradiation like TNT protocol and liver resection, that is the time where you do only short course RT. When you start a neoadjuvant chemo, straight away in that you start a short course 5-dose RT. So by the time you finish your 4 neoadjuvant chemo with cetuximab, bevacizumab or panitumumab, short course RT would have taken care. Then straight away, if you have robot, then you go for, I told you initially liver first approach, then come back to this. So you can do, that way you can reduce the time. So short course RT to start and then give neoadjuvant is how to integrate. I hope this is very clear. This is the only position where short course RT, that is a rapido trial sort of thing we do. And the chemo is common for rectum and this, but don't give too much chemo. As I told you, 4 to 6 cycle, go back and operate. Post chemo FLR is borderline 30. Yeah. So remember, I told you one more thing. What is that? Ideal FLR in a right ideal patient. Ideal FLR in a right ideal patient is what? It is only 25%. So if it is still 30%, I would still give a chance to the patient. I'll explain the patient that there may be some issues, and then I will not try to take higher margins, but I'm going to go ahead and then resect them, because 30 is actually a good thing. You can actually cover them. It doesn't matter. I would do that. But if it is really less, then I would do a portal vein embolization or I would do a hepatic artery perfusion. Then I would actually go back and do that. So, but if they're really less than 25%, those patients then should be considered for liver resection, because now you know that if you cannot do a liver resection, liver transplant has significant survival benefit. So always keep the liver transplant team with you. Give an access to the early liver transplant to that patient, because liver transplant can actually, significant proportion of the patients can be cured. Okay, this is one. Then PV Alston, somebody has written. Then again, how long before surgery do we do a rescan to judge the updated FLR? It would be 2 to 3 weeks. If you have done ALPS 2 weeks, if you have done portal embolization 3 weeks. And if you are doing chemotherapy, then in next 4 weeks you should do that. Otherwise, it's not going to help you. Okay, then let me check next. What are other question? Tumor shrinkage after NACT, do we always take pre-NACT margin? Yes. No pre-NACT margin. Like CA breast. Breast conservation, not like oral cancer. What is left behind is the margin. Nope. If you want to do pre-NACT, then none of them are ever operable. Then imagine there are 5 centimeter two lesion left, right, and you give chemo, they become 1 centimeter. You want to take 6 centimeter margin, then they're never. No. It is proved that the margin in liver metastectomy is what is left behind negative margin, like a CA breast conservation. What is the right time do we decide that PV should not be done? Yeah. Normally, the first assessment of that patient should actually be done after 4 Folfox. After 4, you should immediately image and look, is this patient? That is the right time to operate. Majority get operated by 4. by 6 cycle of Folfox, 6, you cannot make that patient operable. They're never operable. Immediately, I then jump to the portal vein embolization or hepatic artery, chemo port placement. So this is the placement we do. I think pretty much it looks I answered all of them. Probably I didn't leave any of the other questions. Let me see if any of the other questions are left behind. Okay, one more question has come. Rectum with liver mets, what is the right approach? Okay. Short course RT, yes. Core chemo, yes. Liver first, right. Then TNT complete for rectum, then do the rectum robotic lab, right? Absolutely beautiful. First one would be the preferred one. We normally don't use long course RT in this particular patient. Okay. Now what happened? What I will do is the presentation has actually been sent by Kushal. Let me see if I can share this and end the talk after this. Okay. Okay, just a very short one. Just I wanted as a students you to know, because in my center we do this a lot. Okay, I told you what is the general principle. The blood supply from hepatic artery is to the liver tumor, and then the normal liver is supplied by portal vein. So if you can keep a chemo port into this, the anatomical principle suppose that regional chemotherapy to the hepatic malignancy you can give. Second, liver is the place where all the chemo is destroyed. So first dose to the tumor, from their portal system, sinusoids detoxified, then to the systemic. So this is the whole concept that has come. So initial studies as early as 1990 showed that hepatic artery based chemo by pump has very good survival. So now this is the trial, CAL-GB trial, which showed that hepatic artery infusion with 5-FE leucovorin in unresectable colorectal had 47% survival response and 24% survival. So in the MSKCC group that published recently, 64 patients with unresectable, in spite of everything I showed and did, when you do hepatic artery port place therapy, 73% had a response, 67% prior to chemo, 86, and 52% were converted. Can you imagine? 73% response, 50% ends up with surgery, and they had a 94-month survival benefit. So this is a procedure that is done. We do robotic in my center. When you give chemo through the hepatic artery, it should not go to other organ to cause ulcer. If right, you know that right gastric comes from hepatic, if chemo goes through the pylorus, ulcer will happen, patient will have hematemesis. So right gastric artery is clipped. Right gastric artery gives cystic artery, and gallbladder will develop cholestasis, so gallbladder is removed. Then there are some branches from gastroduodenal and hepatic going into the duodenal complex proximal. So we devascularize all of them. So the procedure what we do is we remove all this, then we cannulate the gastroduodenal artery, keep it at the junction of the common hepatic artery, proper hepatic artery and GADA, and then we give methylene blue to see both lobe of liver is taking up, and no methylene blue extravasation into the stomach duodenum, so we ligate all of them. So this is actually the procedure. It's done by a pump which we do in our hospital. So if you actually go back and visit the YouTube on my channel, I put a video. Please go back and see. So you should never avoid a patient who will get benefited by this. Okay, so that completes. I think I answered all the talks. Let me check any other Q&A is there. I think I've answered all of them. Superb. So can we combine portal embolization with this? Yes, definitely you can combine. You can even do microwave ablation. Okay. So thank you very much. This completes. So now you know actually how the oncology is actually moving, isn't it? What we thought as stage 4 becomes curative, what we thought as not operable, resectable becomes operable, and how a MDT changes everything. Okay, so you can read a lot of papers I have published, and on my YouTube channel there are a lot of videos pertaining to this, which we do. Initially we used to do open, now it's all robotic. So imagine patient walking home in 3 to 4 days with all these surgeries, putting a port, chemo, and ending up with curative resection. Thank you very much, and have a nice day. And back to Saurabh-ji, Amit-ji, back to you.
Thank you, Randy, and all the facility members for the session. Thank you, sir.
Thank you. Bye-bye. Have a nice day, all of you.
You too, sir. Thank you, sir.